for joining. This is Yale Highlights of ASH 2021, presented by Yale Hematology. And today's seminar is presented by the Program for Multiple Myeloma and Gammopathies. And we have really fantastic set of speaker presentations today. Our program presented by Dr. Gorshein, our clinical expert in hematology, Dr. Terri Parker, who's the clinical leader of our program with extensive experience and expertise in clinical trials, Dr. Noffar, who's our expert in cellular therapies and transplantation in myeloma, and Dr. Sabrina Browning, who has expertise in preclinical studies and AL amyloidosis. And I'd just like to share the structure of today's seminar. First, Dr. Gorshein will present updates in smoldering multiple myeloma and newly diagnosed myeloma. This will be followed by Dr. Terri Parker with updates in relapse and refractory myeloma. Later, Dr. Barr will present updates on cellular therapies in myeloma, and followed by Dr. Browning, who will present updates on basic science in myeloma and some clinical updates on AL amyloidosis. And we will devote a few minutes in the end for the question and answer and discussion session. So again, welcome everyone. Thank you all for joining. And Dr. Gorshein, please, you may proceed. We can see your slides if you just can project in the slide view on the bottom.
There you go. Got it. Okay, perfect. Can you hear me now?
Yes.
Okay.
Thank
you. All right. So thank you, Natalia. Hello, everyone. So as Natalia mentioned, I'm going to rehash ASH from a perspective of updates on smoldering multiple myeloma and newly diagnosed multiple myeloma. Here are my disclosures. All right, so multiple myeloma is consistently preceded by precursor states of monoclonal gammopathy of undetermined significance and smoldering multiple myeloma. And these essentially represent a continuum of progression of the tumor burden with clonal evolution and heterogeneity. Now, we understand the heterogeneity of smoldering multiple myeloma. In clinical practice, we often rely and apply on the 20-20 rule, which is 20% bone marrow plasma cells, a monoclonal protein of greater than or equal to 2 grams per deciliter, and a free light chain ratio of greater than 20. Patients with 2 or more of these risk factors or components are essentially considered high risk. And this subset of patient population has been evaluated for early therapeutic intervention. Now, with respect to early therapeutic intervention, we know that lenalidomide can be beneficial for patients with high-risk smoldering myeloma. So the rationale here is that triplet therapy, which we use for multiple myeloma, may yield deeper responses and improved outcomes for the smoldering population. And I'm just going to highlight one study on the combination of ixazomib, a proteasome inhibitor, lenalidomide, an immunomodulator agent, and dexamethasone in high-risk smoldering multiple myeloma. Now, in the interest of time, I'm going to essentially only discuss the conclusion slide. But this triplet therapy regimen in high-risk smoldering disease, an all-oral regimen, demonstrated a very high overall response rate of more than 90%, with deep response rates of greater than, deep remission rates of greater than 40%. Now, there were notable grade 3 toxicities for these patients, but importantly, no patients discontinued therapy due to these adverse events. So this is encouraging data, suggesting a potentially more biologically sensitive phase of the disease to treatment, and really highlighting an ongoing area of research in the smoldering multiple myeloma disease. Now, a couple of words on multiple myeloma. So we're going to transition out to multiple myeloma, symptomatic multiple myeloma. We're all familiar with VRD as our backbone to therapy, bortezomib, lenalidomide, and dexamethasone, proteasome inhibitor, IMiD, and steroid. This is a very efficacious treatment regimen, very durable, has a well-established track record. Historically, neurotoxicity was a major concern here, but this has become significantly less of an issue with the once weekly dosing as opposed to twice weekly dosing, as well as with the subcutaneous version as opposed to the IV. So VRD is our suitable backbone, and that has been sort of the impetus for developing quadruplet-based therapies. We know from some data that quadruplet regimens can be very active in the upfront treatment-naive patient population. But there are unanswered questions, and we need more information. How does this regimen impact the high-risk patient population? What about those that are stem cell transplant eligible versus ineligible? And clearly, we need more long-term results that we currently have for VRD, but is not quite there yet for the quadruplet therapy. So moving on to the updated Griffin analysis. So this was published in ASH, looking at the 24-month follow-up for Griffin. Just a brief background on this. So induction therapy followed by high-dose therapy with autologous stem cell transplant and lenalidomide maintenance therapy is a standard of care regimen for newly diagnosed patients. The phase 2 Griffin study that was initially presented well over a year ago evaluated the efficacy and safety of DARA plus RVD versus RVD induction, followed by auto transplant for newly diagnosed transplant eligible patients. The primary analysis after almost 14 months of therapy showed that the quadruplet therapy significantly improved the stringent CR rates versus the triplet therapy by the end of the post-auto consolidation phase, with response rates of 42 versus 32%. We also saw that this quadruplet treatment deepened the responses, improved MRD negativity rates after 1 year of maintenance therapy when the standard of care lenalidomide, when daratumumab was added to the standard of care. Importantly, there were no new safety concerns, and daratumumab did not impact the ability to mobilize stem cells. And patients who received DARA induction were actually able to successfully complete the transplant. So here in ASH, they reported the updated efficacy and safety from Griffin after 24 months or 2 years of maintenance therapy. An overview of the treatment design. So again, patients were transplant eligible, newly diagnosed disease. They received 4 induction cycles of, they were randomized to either the quadruplet or the triplet with RVD. They subsequently underwent stem cell transplant, followed by 2 cycles of consolidation treatment. And then patients were continued to DARA-REV maintenance or lenalidomide maintenance for up to 2 years. The primary endpoint here was stringent CR. Secondary endpoints included various response rates, MRD negativity, progression-free survival, and overall survival. In the bottom half of the slide, you note that the patient characteristics were fairly well balanced between both groups. Now, highlighted here is what's important to note here is that these responses deepened over time. After 2 years of maintenance therapy for the DRVD, the complete response rates were 82% versus 61% for the triplet therapy. And on the right here for the subgroup analysis, you can appreciate that that these improved durable responses were seen irrespective of the various subgroups described. In the lower half of the slide, we note that there were more significant MRD negativity rates with increased treatment as well. Again, for the quadruplet therapy, 64% relative to 30% in the triplet therapy. And when we look at the various subgroup analyses, this finding was also observed for patients over the age of 65, advanced ISS, high-risk cytogenetic analyses, and the revised high cytogenetic risk profile. The median progression-free survival was not reached in either arm, although what's important to note here is that we do see a separation of the curves beginning 1 year after maintenance therapy. So this suggests a benefit for the daratumumab lenalidomide maintenance arm. And although it was not powered, again, not powered for progression-free survival in the subgroup analysis, but you can also note here generally a positive trend for dara-len maintenance versus lenalidomide monotherapy as maintenance. So to summarize these conclusions, so the quadruplet therapy as induction, post-auto consolidation, and dara-rev maintenance is an effective regimen for newly diagnosed transplant-eligible patients. The MRD negativity rates were highest for the quadruplet followed by dara-rev maintenance. These patients had deeper levels of MRD negativity, greater deepening of the negativity over time as we saw approaching the 2-year maintenance phase. Similarly, the rates of sustained MRD negativity and the subset analysis also trended favorably for the high-risk population as well in terms of the progression-free survival. And again, also this 2-year maintenance was well tolerated for those who received the daratumumab combination. So moving on to the Maya study. Now these results were actually originally published last summer at the EHA meeting, but I'm going to review it here also within the context of this presentation by Dr. Usmani at MSK, who essentially wanted to determine the effects of the Maya on patients with impaired renal function, which is relevant here because really up to 50% of patients can have some baseline renal compromise that can impact our choice of treatment. So the Maya trial, as you may know, evaluated the addition of DARA to RevDex in transplant-ineligible patients, newly diagnosed. Median follow-up of 4.5 years, the DARA RevDex prolonged PFS and OS versus RevDex alone. And this was despite the fact that almost half the patients in the RevDex population received subsequent therapy, including a daratumumab-based regimen. So important for this patient population. When we look at the study design, so Maya trial again included transplant-ineligible, newly diagnosed multiple myeloma patients, randomized to DARA RevDex or RevDex. And important here to note is that this treatment was continued until disease progression. The primary endpoint for the study was the progression-free survival. Various secondary endpoints, again, looking at the response rates, MRD negativity, overall survival. And here we note the updated results. So with respect to the updated 5-year analysis, the progression-free survival was not reached for the DARA-RevDex combination and was 34 months for the RevDex cohort. In terms of the overall survival benefit, we do really important here to note is that there is an overall survival benefit for DARA RevDex, which is documented as a 32% reduction in the risk of death relative to RevDex alone. And if you see here on the right side of the screen, regardless of whether patients received a lenalidomide dose of 25 or a lower dose, there was a progression-free survival benefit and an overall survival benefit for DARA RevDex relative to RevDex. And the figure on the left here really just highlights that this progression-free survival benefit that we're seeing in Maya is quite remarkable and really superior to some of the other recent phase 3 trials published in transplant-ineligible patients. To summarize, so after 5 years of follow-up, the progression-free and overall survival benefit for Dara-Rev-Dex versus Rev-Dex was observed. And importantly relevant here, this was also observed in patients with compromised renal function at baseline, irrespective of the starting dose of lenalidomide. Was a little bit less pronounced in those that had a lower dose, lower than 25, but really highlighting the impressive practice-changing results of Maya for transplant-ineligible patients. In the interest of time, I'm just going to briefly review another quadruplet-based treatment regimen presented at ASH just back in December, involving isatuximab, which is another CD38 monoclonal antibody. And here, it involved isatuximab with RVD or ISA-RVD relative to RVD in transplant-eligible patients. And this was the phase 3 GMMG HD7 study. And this phase 3 trial demonstrated a improvement or superiority in MRD negativity rates after induction with the addition of the isatuximab antibody to RVD, with a MRD response rate of 50.1% relative to 35%. And on the right side of the screen, you can also is the highest described to date in a randomized phase 3 trial at 50.1%. Importantly, the addition of isatuximab had no significant impact on the safety profile or dose intensity. And there are ongoing studies evaluating this combination of treatment for transplant-eligible and transplant-ineligible patients. And finally, I think it's also important to discuss the MASTER trial, which involved daratumumab, carfilzomib, lenalidomide, and dexamethasone, autologous transplant, and MRD response adaptive consolidation. We know that daratumumab improves outcomes when combined with a proteasome inhibitor and or an immunomodulator agent. We also know that MRD negativity has prognostic implications. Now, this study incorporated a response adaptive therapy to achieve MRD negativity and really aimed to evaluate the natural history of patients with sustained MRD negativity. Now, the treatment included Dara-KRD, and carfilzomib was dosed at 56 milligrams per meter squared weekly. Patients received 4 induction cycles of Dara-KRD, followed by autologous stem cell transplant, and up to 8 cycles of Dara-KRD. MRD was assessed at each of these blocks. Now, patients who had 2 consecutive MRD negativity findings were transitioned to this phase called MRD Shore, which was a treatment-free interval observation and MRD surveillance. Those patients who did not achieve MRD Shore continued to receive lenalidomide maintenance as the standard of care. And here are the results. You can appreciate that overall, the majority of patients at 80% achieved MRD negativity. And the depth of response and MRD negativity improved at each therapy phase, as you can appreciate with these blocks, and became comparable among the groups with no high-risk cytogenetic abnormalities, 1 high-risk cytogenetic abnormality, or 2 or more high-risk cytogenetic abnormalities. When they assessed MRD at a level of 1 times 10 to the minus 6, 66% of patients achieved MRD negativity. The proportion here in the various cytogenetic abnormality populations was somewhat lower, and it did take longer to achieve for those with ultra high risk, as you can see here in the 2+ high-risk cytogenetic abnormalities. In terms of MRD Shore, so about 71 or 72% of patients achieved MRD Shore, and this was relatively similar across the 3 cytogenetic risk groups. The median follow-up time here was about 14 months, And the risk of MRD resurgence or clinical progression was 4, 0, and 27% among the standard, high risk, and ultra high risk patient groups, respectively. And importantly, none of the patients who entered this phase of MRD Sure ultimately died from multiple myeloma progression. So in conclusion, next generation sequencing MRD response adaptive therapy is feasible in the overwhelming majority of patients in multi-center settings, with 70 to 72% of patients reaching MRD Sure. Patients who have standard and high-risk newly diagnosed myeloma had similar depth of response and low risk of MRD resurgence or clinical progression when they were treated with the master trial quadruplet stem cell transplant and MRD adaptive treatment cessation. And quadruplet therapy, achievement of confirmed MRD negative responses, enables us to explore stopping treatment as an alternative to continuous MRD therapy, to continuous indefinite treatment. Importantly here again, novel effective consolidation treatments should be explored to improve outcomes and clear MRD to a negative state in these ultra high risk patient population. Thank you, and I will welcome questions at the end of this presentation. And I'll transfer it over to Terri.
Thank you. I will be focusing on updates in relapsed refractory myeloma. I have no disclosures. I will be specifically focusing on treatment of triple class refractory patients. This is defined as those patients that are refractory to an immunomodulatory agent, a proteasome inhibitor, and a CD38 monoclonal antibody. Currently approved agents for this class of patients include standard chemotherapeutic regimens, selinexor combinations, venetoclax for patients who harbor a translocation 1114, and 2 BCMA-targeted therapies, belantamab mafodotin, an antibody-drug conjugate, and ide-cel, a CAR-T therapy. Fortunately for our patients, there are many agents currently in clinical trial, many of which were updated at this year's ASH. These include BCMA-targeted therapies in the form of BCMA CD3 bispecific T-cell engagers, non-BCMA-targeted therapies, and CAR-T or cellular therapies, which will be discussed by Dr. Barr later in the session. First, we'll start with a presentation by Dr. Moreau entitled Updated Results from Majestic-1, a phase 1/2 study of teclistamab. Teclistamab is a BCMA CD3 bispecific antibody. Here, phase 1 and 2 data from the 1.5 mg per kg dose was presented. Key eligibility criteria included that patients be triple class exposed, have 3 or more lines of prior therapy, and importantly, no prior BCMA therapy. Patients received step-up dosing at 0.06 and 0.3 mg per kg subcutaneously, followed by weekly treatment of 1.5 mg per kg subcutaneously. The primary endpoint for the trial was overall response rates. 40 patients were accrued in phase 1 and 125 in phase 2. The median treatment duration was 5.9 months. 38 patients had high-risk cytogenetics, 20 with ISS3 disease, and this was a heavily pretreated patient population with 5 median prior lines of therapy. Again, 165 patients were triple class exposed, with 128 being considered triple class refractory and 50 pentadrug refractory. The median follow-up was 7.8 months, and an overall response rate was 62%. With 58% achieving a VG-PR or better and 28.7% achieving a CR or better. Importantly, the overall response rate of 62% was consistent across clinically relevant subgroups, including those patients that had high-risk cytogenetics and those that were pentadrug refractory. The median time to first response was 1.2 months, with a progression-free survival rate at 9 months of 58.5%. In patients who did achieve a CR or better, MRD negativity rate was 41.9%. And looking at the safety data, the most common hematologic treatment emergent adverse event was neutropenia, occurring in 65.5% of patients, while the most common non-hematologic treatment emergent adverse event was cytokine release syndrome, occurring in 71.5% of patients. And taking a closer look at CRS, the median time to onset was 2 days, with a median duration of 2 days. 60 patients did require supportive care with tocilizumab. The conclusions from this presentation was that the overall response rate with tocilizumab was 62%, with responses that were durable and deepened over time. Treatment was well tolerated with no dose reductions. The most common adverse events, again, were CRS and hematological events. The CRS were all low grade, and 97% occurred during the step-up dosing or cycle 1 of treatment, and there was only one grade 3 event which resolved. ICANS events were rare. If they occurred, were all grade 1 and 2 and resolved. Moving on to another BCMA-targeted BiTE, Dr. Zonder presented early, deep, and durable responses with low rates of cytokine release syndrome with Regeneron 5458. Regeneron 5458, again, is a BCMA CD3 bispecific antibody. This was a phase 1/2 first-in-human study with key eligibility criteria, including 3 or more lines of prior therapy, and these patients had to be triple-class refractory. Part 1 was a dose escalation utilizing a modified 4+3 design with dose ranges from 3 to 800 milligrams. Part 2 will be a dose expansion at the recommended phase 2 dose. Step-up dosing was utilized for week 1 and 2, followed by weekly dosing, and then every other week dosing after 16 weeks. Primary endpoints included safety, tolerability, and to determine the recommended phase 2 dose. Data for 73 patients in phase 1 were presented. The median number of prior lines was 5, and 38% of patients were pentadrug refractory. And looking at the safety data, the most common hematologic treatment emergent adverse event was anemia, seen in 32% of patients, followed by lymphopenia and neutropenia. The most common non-hematological treatment emergent adverse event was fatigue. Interestingly, cytokine release syndrome was only seen in 38% of patients. This was questioned in the presentation at ASH, and there was not a good reason available as to why the rates of CRS were lower here compared with other bispecific T-cell engagers. It was postulated that it may have to do with the step-up dosing and or pre-medications. And looking at the efficacy, the overall response rates was 51%. This increased to 75% when you look at doses of 200 to 800 milligrams with a VGPR better of 58.5%. The median time to response was less than 1 month, with 70% of responses occurring within the first 2 months. The duration of response was not reached. And in patients who achieved a CR or stringent CR who had available MRD data, 4 out of 10 patients were MRD negative at 10 to the minus 5. So in conclusion, the authors showed that Regeneron 5458 yielded early, deep, and durable responses, seen as an overall response rate of 75%. 58% achieved a VGR or better, again at the higher doses of 200 to 800 milligrams. 86% of responders achieved a VGPR or better, with a CR or better rate of 43%. The probability of responders being event-free at 8 months was reported as 90.2%. They showed an acceptable and manageable safety profile as the maximum tolerated dose was not reached, with CRS being reported in only 38% of patients. The majority of events were grade 1, occurred within the first 2 weeks, and resolved within 1 day. The phase 2 portion of this study is currently recruiting. In moving away from a BCMA target, Dr. Krishnan presented updated phase 1 results from Monumental-1, a first-in-human study of talquetamab. So talquetamab is a G protein-coupled receptor family C group 5D member D, as also known as GPRC5D CD3 bispecific antibody. She presented updated data at the first recommended phase 2 dose and initial results from patients treated at a second recommended phase 2 dose of 800 micrograms per kilogram Q2 weeks. Patients had to be relapsed refractory or intolerant to all established myeloma therapies and have measurable disease. Previously, a recommended phase 2 dose of 405 micrograms per kilogram weekly subcutaneously was identified. Step-up dosing was utilized and pre-medication was given before all step-up dosing and the first full dose. The primary endpoint was to identify the recommended phase 2 doses. 30 patients received weekly dosing and 25 at the Q2 weekly schedule. 3 patients in each cohort had high-risk cytogenetics. The median number of prior therapies was 6 and 5, and 8 and 4 patients respectively had prior BCMA-directed therapy. In looking at the hematological treatment emergent adverse events, the most common was neutropenia in 67 and 44% of patients, followed by anemia and lymphopenia. The most common non-hematologic treatment emergent adverse event was cytokine release syndrome, seen in 77 and 72%. It should be noted that 75% of patients did have skin and or nail-related findings in the study, the most common being skin exfoliation in 37 and 36% of patients. And taking a closer look at the CRS, again, it was 77 and 72%. The median onset was 2 days with a median duration of 2 days. 63.3% and 60% of patients in the two cohorts did require tocilizumab for supportive care. And looking at overall response data, the median follow-up was 9 and 4.8 months. They showed an overall response rate of 70% and 67.7% for the Q2 week dosing, with VGPR rates of 53.3 and 52.4. The trial also showed that the overall response rate held in patients who were triple class refractory at 65.2 and 66.7%, and in patients who were pentadrug refractory at 83.3%, although the numbers are low with 5 out of 6 patients. The median time to response was 0.9 and 1.2 months, and the median duration of response was not reached. So in conclusion, the tilcatinib 800 microgram per kg Q2 week dosing appeared to have comparable efficacy and safety compared to the weekly dosing at 405 micrograms per kilogram. No new safety signals were reported. Overall response rates range from 67 to 70% across triple class and pentadrug refractory patients. And a phase 2 expansion study of both of these recommended phase 2 dosing is ongoing. And moving away from the bispecific antibodies, a presentation was done on modakafusp alpha, which is immunocytokine, shows clinical activity, updated results from a first-in-human phase 1 study. So modakafusp alpha is a first-in-class immunocytokine designed to deliver attenuated interferon alpha to CD38 positive cells. Patients were eligible if they had 3 or more prior lines of therapy, were refractory or intolerant to at least one PI and IMiD, and could have prior daratumumab exposure within a washout period of 90 days for patients who had received more than 5 months of therapy in the escalation portion. The primary objective was to determine the maximum tolerated dose. In the dose escalation phase, a 3+3 design was used, looking at 4 different schedules. In the expansion phase, they looked at a dose of 0.4 mg per kg every 3 weeks with or without dexamethasone. Data was presented on 29 patients. 7 of 25 patients that had cytogenetic data were considered to be high risk. The median number of prior lines of therapy was 7. 28 patients had prior CD38 monoclonal antibody treatment. 26 of those patients were considered to be monoclonal antibody refractory, and 15 patients had prior anti-BCMA directed therapy. The maximum tolerated dose was exceeded at 6 mg per kg Q4 week dosing due to dose-limiting toxicities of a grade 3 infusion reaction and prolonged grade 4 thrombocytopenia and neutropenia. At the 1.5 mg per kg Q4 week dosing, 1 patient did have a grade 3 bleeding event, but was able to remain on treatment, and 3 patients had grade 3 infections. The most commonly seen treatment emergent adverse events at the 1.5 mg per kg Q4 week dosing were hematologic, with thrombocytopenia occurring in 76% of patients and neutropenia in 69% all grades. Infusion-related reactions did occur in 31% of patients. Most of these were grade 1 and 2. The median follow-up was 4.2 months, and the overall response rate was 38%. Of note, the overall response rate held at 38% in patients who were CD38 monoclonal antibody refractory. The median time to response was 1 month in those patients who achieved a PR or better, with a median duration of response not being reached. The median progression-free survival was 5.7 months. So in conclusion, modakafusp alpha showed promising single-agent activity in patients who were heavily pretreated, including patients who were refractory to a CD38 monoclonal antibody. Had a manageable safety profile. Q4 weeks was identified as the optimal dosing interval, and further enrollment identified the maximum tolerated dose as 3 mg per kg. A randomized phase 2 trial is planned in order to determine the optimal single-agent dosing. Lastly, Dr. Loniel presented iberdomide in combination with dexamethasone in patients with relapsed refractory myeloma, results from the dose expansion of the CC220MM001 trial. Iberdomide is a novel cereblon E3 ligase modulator, also known as a CELMoD. This was a phase 1/2 study that evaluated EBER with different combinations of treatment. Previously, the recommended phase 2 dose was identified as 1.6 milligrams days 1 through 21 every 28 days when given in combination with dexamethasone. Here, he reported safety and efficacy in the dose expansion cohorts, cohort D, which is EBER plus dex, and cohort I, which was EBER plus dex in patients who had prior BCMA treatment. For both cohorts, patients had to have 3 or more lines of prior therapy, and again, for cohort I, all patients had treatment with a prior BCMA targeted agent. 107 patients were treated in cohort D and 26 in cohort I. 32 patients and 6 patients respectively had high-risk cytogenetics in the 2 cohorts. The median number of prior therapies was 6 and 7. In cohort I, 6 patients had prior CAR-T, 18 an antibody drug conjugate, and 8 a bispecific T-cell engager. The most common adverse events were hematologic, with neutropenia occurring in 59.8% in cohort D and 42.3% in cohort I. Infections were common, 57.9% all grade in cohort D and 50% in cohort I. And looking at the response data, the overall response was 26.2 for cohort D and 25% in cohort I. Again, these are the post-BCMA treated patients. Additional data was presented for cohort D with a median duration of response of 7 months, a median time to response of 4.21 weeks, and a median progression-free survival of 3 months. The authors concluded that in heavily pretreated patients, again, 97% were triple-class refractory, the combination of EBER and dex demonstrated clinically meaningful and durable responses. The treatment was well tolerated with adverse events that were deemed manageable with dose reductions and interruptions in treatment. The majority of grade 3 or 4 treatment emergent adverse events were primarily hematological, and this supported the future development of EBER-based regimens, including combination studies with proteasome inhibitors and CD38 monoclonal antibodies. I will stop there. As previously stated, all questions will be answered at the end of the program. Please encourage you to submit this in the Q&A portion, and now I will turn it over to Dr. Barr.
Thank you, Terry. So I'll get started. I'm focusing on CAR T cell therapy in the relapsed refractory myeloma patients. I want to highlight that patients who are refractory to IMiDs, proteasome inhibitors, and anti-CD38 antibodies have a poor prognosis. These are triple-class refractory patients. And when these patients, if they get another line of treatment, the chance that they will respond to another agent is roughly 30%. If they respond, the median progression-free survival is often less than 6 months, with median overall survival often less than 1 year. Now, I want to show you how this is no longer the case. As most of you already know, that in 2021, the FDA approved the first CAR T cell product in myeloma. This is called ide-cel, formerly known as BB2121, and now the trade name is Abecma. This is a CAR T cell product that has a 4-1BB co-stimulatory domain, and it binds to BCMA on the cell surface of the tumor cell. It's approved for patients who are refractory to IMiDs, proteasome inhibitor, and anti-CD38 antibodies. 76% of the patients responded. About a third of the patients achieved deep responses, CR, and stringent complete response. Most of those patients were MRD negative, attended negative fifth using next generation sequencing. Now, these patients had initially dose escalation, so not all of them received the same dose. If you look at the total population, the median progression-free survival was 8.8 months. But if you hone in on the target dose, the patients that received the target FDA-approved dose, it is about 1 year. All of the population, median overall survival, 24 months. Now, we also know that deep responses lead to longer duration of response. And here I show you a graph where patients who have a CR, complete response, or higher, exemplified by the light blue line, compared to very good partial response by the purple line and a partial response by the dotted purple line, clearly you see that these curves spread out. And a median of 2 years of follow-up, those patients who have a CR or higher had a median duration of response of 21 months. So that's almost 2 years. Now, I showed you before that only about a third of the patients got into this deep responses. So it's interesting to figure out who are the patients that went into these deep responses, and perhaps who are those that don't respond as well to Abecma. And this was presented by Nina Shaw this year's ASH. And she looked at disease characteristics at baseline and correlated it with patients who had a CR or not. What they found is that patients who did not have a CR tended to have a higher soluble BCMA. Now, BCMA is a receptor on the cell surface of tumor cells, but it can be cleaved and then circulates in the bloodstream as soluble BCMA. It's often seen with higher burden of disease, and it can serve as a sink. So if you're giving the targeted CAR T, right, instead of going to the tumor, it's going to the soluble BCMA. So you can imagine how this would prevent its efficacy. The other thing they noted is that patients not achieving a CR tended to have a high an increase of inflammatory markers by having higher ferritin or D-dimer. Now, these could be patients who are sicker, more burdened of disease, and you might think maybe perhaps this this inflammatory microenvironment can impede T-cell functionality. But again, this needs to be further dissected. These are just the start of trying to understand biomarkers for response, and need to be tested in larger cohorts. They did find that having a higher vector copy number in the drug product was more associated with patients who had a CR. Now, we know that number of CAR T is not the full picture. We also understand that quality of T cells are important. And this is a diagram showing you the T cell differentiation from the naive T cell all the way to the T effector cell. These earlier T cell, the memory-like phenotypes, have some key qualities that make it quite attractive for CAR T products. Example, they're long-lived, so they last longer. They have ability to self-renew, and they have a T cell plasticity. Furthermore, these memory-like T cells were correlated with peak expansion and sustained response in CAR T studies. So this brings me to the next abstract, which was presented by Dr. Raj, and it looked at using a PI3 kinase inhibitor, BB007, which is known to enrich memory-like T cells, and combine it with ide-cel in vitro. And this product was now termed BB21217. And the hypothesis is that higher memory-like T cell in the cell product will improve duration of response. The patient characteristics here were similar to other CAR T studies. I want to highlight a few things. This was a dose escalation study. So 46 patients out of the 72 received the target dose. High-risk cytogenetics were found in 39% of the patients. This is slightly higher than what was reported with Abecma, which was around 27%, and extramedullary disease was 22%. Safety profile with BB21217 was similar to Abecma. I'm not going to go into the details, but briefly, CRS, 75%, mostly grade 1 and 2. ICANS, which is the neurotoxicity that we see with CAR T cells, was 15%, very comparable. Cytopenias are very common in general with all CAR T cells relating to the lymphodepletion that they get before. And the grade 3 and above infections, which is clinically very meaningful, is about 30%. In terms of efficacy, the overall response rate was 74%, 39% with a CR, most of them being MRD negative. Now, this doesn't look very different than Abecma information, but really what this study is looking at is duration of response, which I'll show you in this slide. So a median follow-up of about 2 years, the median progression of free survival for patients getting the target dose was 18 months. And in Abecma, I put in gray here, was 12 months. Now, this is not a head-to-head comparison by any means, but I want to give you this as a framework to kind of digest the results here. Now, in patients who achieve deep responses, CR and above, The median duration of response was 34 months, and in Abecma, this was 21 months. They did see that memory-like T cells in both the CAR T product and a peak expansion in the patient was associated with better response and duration of response. So this is a good example of how you can build on an already established CAR T product. The next topic will be focused on information, updated information on the CAR T cell product that will be approved next, and this is Cilta-cel. Cilta-cel is also an anti-BCMA CAR T. It also has a 4-1BB co-stimulatory domain. The difference is it has two binding domains here extracellularly. So this was a 2-year follow-up of the phase 1b/2. Patient characteristics are represented here. They had almost 100 patients, heavily pretreated, similar to other CAR T studies. Perhaps the percentage of triple refractory, right? This is triple class refractory, it's a little bit higher, 88%. They do comment on penta-refractory, so that's refractory to 2 IMiDs, 2 PIs, and 1 and a CD38 antibody. So this was seen in 42%. They had 23% high-risk cytogenetics, mostly deletion 17p. And they did have 19 patients with extramedullary disease. 13 patients had extramedullary disease plasmacytomas outside of the bone, which is a higher risk feature. So efficacy, I showed you part of this last year, but there are some updates. Overall response rate, 98%, which is great. So literally 2 patients here did not respond. However, one of those patients wasn't evaluable because, or they couldn't really assess response because he didn't have measurable disease, but they did clinically respond. So really only 1 patient did not respond to this. And deep responses, as you see here, 92% stringent complete response is really unprecedented. The median time to first response was 1 month, and the median time to best response was about 2.5 months. At a 2-year follow-up, the median progression-free survival, overall survival, and duration of response was not met. They further looked at MRD at 10 to the -5th based on next-gen sequencing. In 61 patients, 92 were MRD negative. 30 patients had sustained MRD at 6 months and above, and 18 had sustained MRD at 12 months and above. Now looking at progression-free survival based on depth of response. So patients who had a CR, stringent CR, is exemplified by the green line here, had a 2-year progression-free survival of 71%, compared to 60 for the total population. Now going deeper, sustained MRD responses at 6 months and 12 months had a progression-free survival of 91 and 100% at 2-year follow-up. So this is really fantastic. You might be wondering what is driving the blue curve down. You know, a lot of these patients did achieve really great responses. And they did do a subgroup analysis trying to understand this. And they found that the 2-year progression-free survival was lower for patients who had baseline plasmacytomas, high-risk cytogenetics, and high tumor burden. So this is important to keep in mind. Certainly these patients benefit, but they might not benefit as well as others. Safety. CRS was extremely common. Almost everyone had it, mostly grade 1, followed by grade 2. They did have a good amount of use of tocilizumab at 70%, which is higher than what's reported with Abecma, around 50%. The ICANS neurotoxicity was comparable, 17%, infections grade 3 or above 20%. There was 6 deaths related to Cilta-cel, predominantly driven by infections, and it followed by CRS and neurotoxicity. They saw 15 events, secondary primary malignancy in 11 patients, which were felt unrelated to the from Cilta-cel. And the thought is that this is not out of the usual for this multiply relapsed, heavily pretreated myeloma patient population. One thing to note that is different with Cilta-cel as opposed to ide-cel or Abecma is that the CRS, it has a later onset, the median of 7 days after infusion compared to 2 days after Abecma. So it is a great possibility to give it in the outpatient setting, and it is being tested in clinical trials like that. Last thing to comment about cilta-cel is this movement and neurocognitive adverse effects. When the cilta-cel was first given to patients, they saw the incidence of these at 12%, and actually was concerning. The risk factors that they found to develop this was high tumor burden, high CAR T cell expansion and persistence, development of ICANS, and CRS grade 2 or above. So Jansen and team decided that they need to do something about this and develop patient management strategies, including enhancing bridging therapy to reduce tumor burden before they get the CAR T, and early and aggressive treatment for CRS and ICANS, and probably is what driving the higher use of toci in this agent. With this, there have been no further toxicities, and the current incidence in over 200 patients treated on several clinical trials is 0.05. And this is important because this is what held up the FDA approval of this drug last year, and now seems to be much better, in much better shape, and will likely be approved next week. I do want to highlight that cilta-cel is being used earlier in the treatment course for myeloma, and we will have a study open here using cilta-cel as part of upfront treatment for myeloma. The last topic I will talk about is another CAR T product that is targeting the GPRC5D protein. This is called mCARH109. GPRC5D is expressed on myeloma cells, as well as skin and hair follicles. It's a receptor that actually no one really understands what it does. This is a small study at Memorial Sloan Kettering, 16 patients. But what is unique is that these are really heavily pretreated patients, very high risk population. So everyone was penta-exposed. Almost everyone was triple class refractory. 60% had prior BCMA targeted therapy, most of that CAR T. 77 had high-risk cytogenetics, including 1q amplification, which we know is very high risk. About half had plasmacytomas, and about 20% had non-secretory myeloma, which is really a patient population not represented in the clinical studies. So this is a swimmer's plot of response, a follow-up of 18 months. Dose escalation, you see here the doses go up. With higher doses, it does seem that there are deeper responses. You can see by the green bars. The follow-up is relatively short for these patients. Overall response rate, about 70%, about a quarter achieved a complete response in all population. So more to follow on that. Safety was manageable. CRS, 93%, similar to cilta-cel. There was one patient that had grade 3 in neurotoxicity. In terms of off tumor on target side effects, nail changes, rash, taste changes, were seen, all grade 1, all transient. So this is a great product. Is furthering, it goes into further development with a multi-center study. So with that, I will end my part of the talk. And move on to Dr. Browning.
Okay, great. So thank you again to all for joining, and those who may be able to stay on a little bit past the 1 o'clock hour. So with the remaining time, I will review a few abstracts highlighting basic and preclinical work in multiple myeloma, and then provide an update on the management of patients with light chain or AL amyloidosis. And I have no disclosures to report. So this slide outlines the abstracts I will review with you today. I'd note that there were many exciting preclinical updates in myeloma with a focus really on immunology and the myeloma immune microenvironment, as well as advances in genomics and myeloma pathogenesis. And I will highlight abstract 159, which provides us with an updated analysis from a practice-changing study in AL amyloidosis. So to begin, obesity is closely linked to myeloma pathogenesis and has also been associated with increased mortality in multiple myeloma. It is thought that obesity increases the production of pro-inflammatory cytokines and adipokines and leads to ectopic accumulation of adipocytes in the bone marrow, which can change the bone marrow microenvironment. And in this abstract presented by Dr. Xu from the Sun Yat-sen Cancer Center in China, the authors aim to investigate the role of bone marrow adipocytes in myelomogenesis and explore potential novel therapeutic agents targeting the bone marrow microenvironment. They evaluated patients with newly diagnosed multiple myeloma and healthy controls. The myeloma patients were separated into two groups based on BMI and underwent testing from bone marrow that included RNA sequencing, metabolomics, and flow cytometry analysis. And there was an increase in bone marrow adipocytes in patients with myeloma, and metabolomic analysis revealed that several metabolites were very closely associated with BMI, with glycerolipid metabolism enriched in myeloma patients with obesity. RNA sequencing data from the bone marrow adipocytes showed that patients with myeloma had an increased expression of fatty acid binding protein, or FABP4. And this is seen in figures A and B, with FAPB4 having an important role in linking lipid metabolism with immunity and inflammation. And obesity further enhanced the expression of FABP4 in these studies. To further evaluate the potential role of FABP4 in pathogenesis in myeloma, the authors studied a FABP4 knockout and wild type mice who were fed a high-fat diet for 12 weeks. And you can see here in figure C that the knockout mice had less tumor burden by PET scan, and as displayed in figure D, they also had improved overall survival. The authors then applied an FABP4 inhibitor known as BMS 309403, which resulted in significant attenuation of the tumor burden and improved survival in obesity-induced myeloma mice, as outlined in the two figures on this slide. So in summary, these data suggest that bone marrow adipocytes, which are increased in obesity, may shape metabolism and immunity in the bone marrow microenvironment and play a role in promoting myeloma pathogenesis. This certainly requires further investigation, though it does raise an important question regarding whether modification of obesity and other such associated risk factors can serve as a preventative strategy in multiple myeloma. In this next abstract that was presented by Dr. Simone Minnie at Fred Hutchinson Cancer Center, the combination of the immunomodulatory drug lenalidomide and an anti-TIGIT antibody was studied in mice after undergoing autologous stem cell transplantation. As many of you know, high-dose chemotherapy and autologous stem cell rescue has been shown to provide progression-free survival benefit in multiple myeloma, though in myeloma, disease relapses are expected, and there is definitely a need to enhance the anti-tumor efficacy of stem cell transplant. As you can see in the figure here, autologous stem cell transplant via lymphodepletion and immune reconstitution is thought to establish a myeloma immune equilibrium with an inflammatory microenvironment. However, tumor escape is inevitable, and exhaustion of CD8 positive T cells is thought to play a major role in disease relapse. TIGIT, which is an inhibitory receptor, is upregulated on exhausted T cells and is thought to play a major role in disease relapse, with studies showing a strong association between myeloma burden and expression of TIGIT on CD8 positive T cells in mice status post-stem cell transplant. Therefore, as you can imagine, TIGIT has emerged as an attractive target for immunotherapy in multiple myeloma. So in this study, myeloma mice underwent high-dose myeloablative radiation and then received bone marrow grafts, followed by the administration of a anti-TIGIT monoclonal antibody twice weekly for 5 weeks, starting on the day of transplant or day 0, and then lenalidomide administered daily for 3 weeks, beginning on day plus 14. And synergistic anti-myeloma activity was observed with this combination. As you can see in figure B, there was a significant reduction in the rate of tumor growth and also improved median overall survival in the mice who received this combination post-transplant. And the authors also found through flow cytometry and flow SOM clustering that this combination increased T cell memory and reduced exhaustion, as displayed in the representative heat map on the bottom right in figure C. And lastly, the combination of an anti-TIGIT monoclonal antibody and the 4th generation IMiD or CELMoD iberdomide, which was discussed by Dr. Parker earlier in our discussion, is now entering human trials shortly. So to move along, light chain or AL amyloidosis is a rare systemic disorder of clonal plasma cells that generate aberrant or abnormal immunoglobulin light chains, which misfold and form insoluble amyloid fibrils. These fibrils then deposit into extracellular tissues and organs, resulting in impairment of vital organ function and sometimes or often death. With the introduction of novel therapies, there has been improvement in overall outcomes and prognosis for AL amyloidosis, which were historically very, very grim. In abstract 155, which was presented by Dr. Sterin from the Boston University Amyloidosis Center, there was a 40-year natural history study that was reviewed on outcomes for patients with AL amyloid seen at their center. And what they found is displayed on the slide here was that in a cohort of slightly over 2,300 patients, the 5-year overall survival improved from 15% between 1980 and 1989 to 48% in the most recent decade that was studied, which was 2010 to 2019. Median overall survival improved from 1.4 to 4.6 years, and the 6-month mortality rate dropped from 23% to 13% when comparing between these two time periods. However, amyloid remains a challenging disease, both due to delays in diagnosis and challenges with treatment, notably in patients with cardiac involvement, and further advances in therapy are really crucial. So the Andromeda study is a phase 3 randomized open label controlled trial that compares our prior standard of care for amyloid, which was bortezomib, cyclophosphamide, and dexamethasone, or VCD, versus VCD plus the anti-CD38 monoclonal antibody daratumumab, which was administered subcutaneously. And patients with newly diagnosed AL amyloid and cardiac stage 1 through 3A disease were recruited for the study, and both arms received VCD for 6 cycles, with the study, the protocol or daratumumab arm getting VCD times 6 cycles, and then monotherapy with daratumumab every 4 weeks for a maximum of 24 total cycles. Prior analyses at 6 and 12 months revealed that the addition of subcutaneous daratumumab to VCD resulted in deeper and more rapid hematologic responses, also improved organ responses, and prolongation of major organ deterioration progression-free survival. And this data led to DARA-VCD being the first approved therapy for AL amyloidosis in 9 countries, with FDA accelerated approval granted in January of 2021. And so the current abstract presented by Dr. Raymond Comenzo from Tufts University provided an update after a median follow-up of 25.8 months. So these tables outline the demographics and baseline characteristics of patients that have been enrolled in Andromeda, and they were well balanced between the 2 treatment arms. The median age of in the DARA-VCD arm was 62 years, and both arms had a slight male predominance. I would like to point out that only 3 to 4% of patients on both arms in this study identified as Black or African American, which is important in considering the generalizability of these results, and was a discussion when this abstract was presented at ASH, I think really highlighting the importance of improving diversity in our clinical trials, and that includes in trials of plasma cell disorders. 66% of patients had involvement of 2 or more organs, with cardiac and renal involvement being the most common. And importantly, 36% of the patients in the DARA-VCD arm had stage 3A cardiac disease. At the median follow-up of 25.8 months, 77.2% of patients in the DARA-VCD arm had received daratumumab monotherapy after 6 cycles of DARA-VCD, and 36% of patients in both groups had discontinued study treatment. So over 2 years of follow-up, more patients achieved a hematologic complete response in the DARA-VCD arm at 60%, compared to only 19% on the VCD arm. And you can see this hematologic complete responses deepened over time in the DARA group. Patients achieving a very good partial response or better improved from 77% at the time of primary analysis to 79% in this updated analysis. Importantly, hematologic complete response was higher with DARA-VCD in all pre-specified subgroups, and those included groups with cardiac involvement at baseline, those who had cardiac stage 3 disease, and those with translocation 11-14, which makes up about 50 to 60% of our AL amyloid population. And as you can see in these graphs, the cardiac and renal response rates in patients receiving DARA-VCD were significantly higher at both 6 and 18 months when compared to the VCD arm. At the 18-month mark presented at this ASH, both cardiac and renal response rates were more than twice as high as the organ responses that were achieved with just VCD alone. And it's important to remember that organ response in AL amyloidosis can be delayed or lag behind hematologic response, and that organ responses are thought to really improve quality of life in this complex patient population. There were a greater number of deaths related to disease progression in the VCD arm, though with a longer time on therapy, the absolute number of deaths while on treatment was higher in the DARA VCD arm. Serious treatment emergent adverse events occurred in 47% of patients on the DARA VCD arm and 36% of patients receiving VCD alone, with pneumonia being the most common serious adverse event that was observed in both groups. The rate of discontinuation due to treatment emergent events was similar in both groups, and the most common adverse events observed in the study are outlined in the tables at the bottom of this slide. So in summary, after more than 2 years of follow-up, hematologic and organ responses continue to increase with daratumumab VCD when compared with VCD alone. Fortunately, there were no new safety concerns that were identified with this longer follow-up. And overall survival will be analyzed, and major organ deterioration, progression-free survival will be updated after approximately 200 events. Though at the median follow-up presented here of 25.8 months, there were fewer deaths that were observed in the DARA VCD arm as outlined here. And so this updated analysis really confirms the treatment benefit of this regimen out to 18 months and supports DARA VCD as a new standard of care for our patients with newly diagnosed AL amyloidosis. So the final abstract that I will touch upon was presented by Dr. Jason Valent from the Cleveland Clinic, and it reviewed the safety and tolerability of Kale 101 in combination with antiplasma cell therapy for patients with AL amyloidosis. And this was from 1-year results from an open label phase 2 trial. So as we previously discussed, amyloid fibril deposition in organs results in organ dysfunction with significant morbidity and mortality for patients with AL amyloid. And our standard of care antiplasma cell therapy, as just discussed, really decreases the production of amyloidogenic light chains by targeting abnormal bone marrow plasma cells, but doesn't address the amyloid fibrils already present in end organs. So Kale 101 is a chimeric monoclonal antibody, and it binds a neoepitope that's present on both kappa and lambda light chain fibrils, resulting in proteolysis and removal of the amyloid fibrils from tissues and organs. In a phase 1 study of this agent, Kale 101 was well tolerated up to 500 milligrams per meter squared in patients who had relapse or refractory AL amyloid. And in the phase 2 component, it was tolerated up to 1,000 milligrams per meter squared when administered in combination with standard of care antiplasma cell therapy. And this was, the patients recruited had cardiac stage 1 through 3A disease. So 25 patients are included in the analysis that was presented at ASH, and all had a confirmed diagnosis of AL amyloid, at least a 6-month minimum life expectancy, and the patients recruited were not planned for autologous stem cell transplant in the first 6 months of the study. Patients were excluded if they had concomitant multiple myeloma or symptomatic orthostatic hypotension. And subjects received 4 weekly doses of Kale 101 and then bi-weekly dosing until clinical deterioration, toxicity, or death. And as you can see in the schema on the top left of this slide, Part B of the study added daratumumab to the standard of care therapy based on the Andromeda trial. The mean age of the study group was 65.2 years, with the majority being male. 80% of the patients had cardiac amyloid involvement, and 92% of these individuals had cardiac stage 2 or 3A disease. 96% of patients had treatment emergent adverse events, with the most common ones being listed in the table at the bottom right here, though only 24% of those were felt to be related to treatment, and most adverse events were low grade, with the thought that the cardiac safety of this agent was really more well tolerated than expected overall. So though there was a limited number of patients, 18 of the 20 patients with cardiac involvement showed stability or improvement based on the NT-proBNP values, with some of the 35% of those who responded reportedly showing dramatic improvement. And similarly, 8 of 9 patients with renal involvement at baseline achieved renal responses, with more than 30% reduction in their proteinuria, and some patients having very rapid and deep responses. So to summarize, Kale 101 appears to be very well tolerated and safe in combination with our standard of care antiplasma cell therapy, which is now daratumumab plus VCD, and it has yielded cardiac and renal responses in a majority of patients. Kale 101 is now being studied in phase 3 trials for patients with Mayo stage 3A and also stage 3B disease, cardiac disease, which was previously excluded from this and from patients that were previously excluded from this and from the Andromeda trial. So I will stop there and we will move to questions and answers.
Okay, thank you everyone for great presentations. I will start by asking Noffar, could you tell us your perspective on how would you envision CAR T cell therapies in the coming years in the future for transplant eligible patients?
I think that's a very good question. I mean, many studies are looking at that. I think clearly you see unbelievable responses in patients who typically didn't respond like this. So one could imagine even better responses and longer duration of responses in more fit patients with a better immune system and given upfront. So then I think this is what the future is going to be. It's going to be evaluated upfront in transplant eligible and ineligible patients.
Great. And can you comment with either the MCAR or the cilta-cel, were there any subjects included with CNS involvement?
No CNS involvement. These are excluded.
I think within our practice, we have had patients who had CNS involvement and they've been treated. These are anecdotal, but I'm sure it's evolving. I also wanted to ask a question of Dr. Browning. Sabrina, how do you approach treating your frontline AL amyloidosis patients?
Yeah, I think that's an important question because of the role that autologous stem cell transplant has played in amyloid in terms of, improvement in progression-free and overall survival. But I think now, the hematologic and organ response rates in Andromeda with DARA-VCD are really impressive. And I think importantly, the responses occur rapidly, which is important in terms of subsequent organ responses. So I would say that, I think in most of our patients, we should use DARA-VCD. And then the question becomes of those patients who should go on to get autologous stem cell transplant. And I think what we and other centers have adopted is in patients who have achieved a hematologic complete response, the thought is that there may not be additional benefit to auto transplant and that those patients have transplant available to them if they were to relapse subsequently.
Great. And a question for Terri. In this competing environment of therapies for relapse refractory myeloma, where do you position BiTE approach?
Yeah, and that's a good question. So a lot of these trials are still in early phase and they're still in really heavily treated patients. So I think we don't know which one's going to win, right? All of the bispecifics seem to have very similar toxicity profiles as far as CRS, minimal ICANS, hematological toxicity. I do see the bispecifics being moved into that 1 to 3 lines of therapy, especially if we can improve upon the duration of response, similar to kind of what Noffar was saying with the CAR T. And then I believe the question of CAR T versus a bispecific is really going to come up. And the bispecifics may be for those individuals who really can't wait for the CAR T and need treatment sooner rather than later, as the majority of the responses were seen within a month of therapy. And so I think it's going to depend on how extensive the disease is, how quickly a patient needs therapy, and how fit they are overall. But I think we have a question in the chat. If you see it for Dr. Gorshein.
Yes. So the question asks, outside of the clinical trial context, when would you use DARA-RVD in clinical setting, general standard of care?
Is that meant to be DARA-RVD or because it's RVP?
Well, I guess prednisone.
Oh, prednisone. Okay.
Must be
okay.
prednisone or dexamethasone.
That was platinum. So I think that, look, obviously we have a couple of options here, like we discussed, VRD backbone well-established. efficacious. If you're a little more concerned about high risk, there are some centers that would go KRD. But to me, I think that the quadruplet, we see the durable improvement in responses, approaching the 24-month of maintenance therapy. So if a patient can tolerate a quadruplet, whether they're standard risk or high risk, I would strongly consider that.
Yeah, I agree. I think the quadruplet therapies with monoclonal antibody backbone are entering the frontline care, and with more and more data accumulating and data maturing to show, so far it's the MRD superiority, but we know from separate trials that MRD negativity is translates into much improved progression-free survival and overall survival. I think the field is really evolving, and which one will emerge as the next favorite therapy is a big question. I think one has to consider that high-risk patients, situation may still not be optimal, so further work needs to be done for the high-risk population. I think it's hour and 15 minutes, which is the time we provisioned for this seminar. I don't see any other questions. Any other discussion from the panelists here? If not, we will conclude, and thank you very much for participation, everyone. Thanks.
Thank you, everyone.
Thank you.